Hi, my name is Derek Storrs, and this is my CEN case presentation on the knee. My patient was a 30-year-old female full-time veterinarian medicine graduate student. She's also an active runner and cyclist. The examination was performed on the 30th of January. The referral diagnosis from the MD was a compound tibial fracture, approximately 16 weeks post-op. Chief complaint is left quad weakness and associated left knee pain. The date of injury was the 14th of September of last year. Self-reported scores, as measured by the photo, she had a score of 44, whereas the mean score for that condition is a 43. Predicted change was 21, predicted number of visits was 15, and the predicted length of this episode was 59 days. Here's her body diagram. Her P1 was at the left infralateral knee. It was described as an intermittent dull ache, described at the day of examination as a 0, also being her best score, 0 out of 10, and at worst a 4 out of 10. P2 was at the left medial knee. It was described as an intermittent dull pain, and at best it was a 0 out of 10, at worst a 2 out of 10, primarily aggravated by squatting activities. No numbness or tingling was reported, and the relationship between P1 and P2. P2 is a result of weakness and poor mechanics resulting from the surgery at the P1 area. She had a tibial plate and 4 screws and ORIF inserted at that lateral tibia. As far as planning for the physical examination, these are the possible structures involved. Joints under the area of symptoms include the tibiofemoral joint, proximal tibiofibular joint, as well as the patellofemoral joint. Structures which refer to the area include the tibial plateau, the patellar tendon, the menisci at the lateral side where she had her P2 complaint, medial side with the P1, and the IT band. Contractile structures in the area that could be involved include the quadriceps group, the pes anserine group, adductor magnus inserting at the adductor tubercle on that medial side, biceps femoris on the lateral side, the triceps surae, more so the plantaris and gastroc, and the articularis genu on the anterior side. Other possible structures, the plica, patella, patellar bursa, collateral ligaments, and then some of the nerve structures, saphenous having that lower leg and lateral distribution, anterior femoral cutaneous having that anterior thigh distribution, as well as a superficial fibular nerve. The early hypothesis before the interview, these were the two things that we considered. Primarily, hypersensitivity of pain fibers surrounding surgical site with concomitant poor motor control and functioning. She's 16 weeks post-op, as we'll get into. She's done physical therapy in the past, and it could be that, again, there's some hypersensitivity and some pain that's leading to that poor muscle control. Secondary hypothesis is perhaps some patellofemoral pain attributed to the generalized muscle weakness as a result of kind of some poor rehab strategies of the quad and hip stabilizer groups. Symptom behavior. P1 aggravating factors are palpation, standing, or walking for prolonged periods, running, which at this time she was unable to do, squatting, or lifting heavy objects. Easing factors were ice and rest. As far as P2 is concerned, squatting was the only reported aggravating factor, and no easing factors identified, as again it was only aggravated during squatting. Her patient history, her sleep in 24-hour pattern is she's able to sleep with no complaint of waking during the night, and no medication currently needed for sleeping. Duration of the current symptoms, again 16 weeks. Post-injury, mechanism of injury was pretty severe. She was riding her bike home from class when a parked car door was open and she slammed into the door. Suffered a broken toe, a bruised spleen, and compression fracture of the tibial plateau. And this will be a little important later on. She had, again, all of these traumatic events surrounding the initial event that kind of play into her overall pain experience. Progression since the current episode: decrease in pain, significant motor impairment and weakness, intermittent knee buckling, although no falls reported. Significant prior history, again, compression fracture fixated with an ORIF and 4 screws. Patient was non-weight-bearing status for 6 weeks following surgery. Previous treatment included outpatient physical therapy at her local university, and most of the treatment there consisted of ice, ultrasound, e-stim, and stationary bike activities. Medical history: red and yellow flags were screened and were all clear. Special question: she had x-rays on the 15th of December, nothing outstanding, and currently taking glucosamine and chondroitin, which I thought was interesting because those are most commonly used in osteoarthritis. She's a 30-year-old female. But what will you use as asterisk signs from the history? P1, 2 things: reduce pain at worst from a 4 to a 2 out of 10, and decrease the time to onset of P1 symptoms during walking and standing activities. For P2, we just simply want to reduce the frequency of how often those symptoms occur. Again, they occur during squatting. Hypotheses, listed again. Oops. Hypersensitivity of pain fibers surrounding surgical site with concomitant poor motor control and functioning. And the secondary hypothesis that patellofemoral pain attributed to muscle weakness. Initial hypotheses ruled out during history. There weren't really a whole lot that we could look at because several of them require a special test. So no specific musculoskeletal hypotheses to be ruled out, although some are more unlikely than others. As far as non-musculoskeletal is concerned, there is no vascular ischemia supposed based on her history. No complaint of any kind of ischemic symptoms of numbness, tingling, increased pain, redness, soreness. The SINS, what is the severity of the condition? Moderate. She reports variable bouts of knee buckling during gait and associated cessation of recreational running and biking. It has affected her recreational life. In addition to that, it impacts ADLs, as she reports giving way of the knee during stair climbing. The irritability of the condition is moderate. Patient can reproduce symptoms during stair climbing, taking a quick step as if to initiate running, or even in a transfer from sit to stand. But symptoms stop when patient is at rest, so they can be relieved. Symptom aggravated by activity, and time to resolve is a variable time. The primary nature of the statement of the problem is hyperalgesia and associated poor motor control. The stage currently remains the same. It is in the remodeling phase as far as tissue healing is concerned, but kind of more of a chronic pain state, as tissue should be healed. Tissue is in the remodeling phase, but kind of that hyperactive nervous system playing into her overall pain experience. The current stability of the disorder: it's stable and reproducible. Some things to rule out: we did some collateral ligament testing, ACL, PCL, MCL, LCL. No issues there. Meniscus testing with a McMurray and some joint line tenderness. And then overall knee range of motion manual muscle testing. Although she does exhibit weakness in the single leg squat, she has normal manual muscle testing and normal active range of motion within that knee as far as flexion and extension are concerned. Items to defer for day 1: none. Symptoms are provoked by functional movement and easily produced, so she is able to reproduce her symptoms just based on her functional movements. So no need to defer anything per se. However, symptoms should be reassessed as the condition evolves and changes. Physical exam that we did, no contraindications, no precautions, as she's no longer in a non-weight-bearing state, being 16 weeks post-injury. Postural observation, no signs of infection, scar tissue looked good, no swelling, effusion, or obvious deformity. Functional movement, she did have some antalgic gait, spending a little less time in stance phase on that involved extremity. Quick screening test, we looked at the hip and the ankle, normal active range of motion within normal limits, and the neuro exam was within normal limits. As listed here, you can see her knee active range of motion, perfectly normal, and that was actively. And then again, her resting pain of P1 and P2 is a 0 out of 10. It's just with activity that those symptoms are elicited. More on the physical exam. Palpation did tell us a lot. P1 reproduction upon palpation of the lateral quads, some trigger point tenderness on that peroneus longus on the lateral side, as well as the infrapatellar fat pad. So having some muscle compensation was something that we suspected due to kind of the non-weight bearing stance and the instability of the knee and that compensation of the muscles. Unable to reproduce P2 symptoms upon palpation. Again, only reproducible during squatting. Joint restrictions, slightly limited patellar mobility, but other than that, everything looked good. As mentioned before, manual muscle testing of knee and hip was within normal limits. Muscle length was not tested. Motor control, single leg balance was good bilaterally, greater than 15 seconds, although limited single leg mini squat control and strength, poor hip control and awareness. Special tests done were the anterior drawer and McMurray, which were both negative. Kind of our assessment of the situation and our plan is kind of what we've discussed before, that hyperalgesia in the knee and kind of the shutdown of the motor control and functioning secondary to the pain. She's out of the tissue healing phase at this point, and the pain is really beginning to affect her function. As far as our asterisk items that we picked up from the history, she had the increased P1 symptoms during stair climbing. That's definitely something we want to address. The reports of buckling as well, and the fact that she has been unable to return to biking or running. At this point, had all things worked out, the possibility of at least getting into running training, not necessarily running itself, but at least into some running specific rehabilitation could have definitely been an option, as well as the biking. So that's something that we're going to focus on for sure. The physical exam told us that antalgic gait and the poor single leg squat control need to be addressed. Our plan of care, based on the patient's motivation, she is motivated and has the potential to rehabilitate the need to perform gaits, standing, transfer, and recreational cycling activities with no pain in 6 to 8 weeks. Based on bone healing times, return to running long distances may take 6 months. She had done some half marathons before, and at this point in time is unable to take more than 2 to 3 steps in a running stance. So it's going to take some time to dial down that pain, as well as to just be able to get those tissues used to that movement of running. Ideally, we'll see her twice a week for the first 4 weeks, see how things play out, see how she responds to the manual therapy as we get down to the last question there, the dry needling and such, and then after that, taper to once a week as appropriate. Our patient-specific goals for PT are to enhance motor control of the hip and knee, as well as improve static and dynamic balance. We'll know that she's ready for discharge when she's able to perform her HEP independently, when her symptoms are decreased, both P1 and P2, and she's able to begin at least running, on the treadmill, or running inside, or running a short distance, not necessarily half-mile distance, but so that she's comfortable getting back into that stance and that activity. If she's not making progress at 8 weeks, that's kind of the time where we say, okay, let's see what else we can we can do here. Let's see if there's some underlying issues, something that perhaps has come loose, if something's not going right there at the surgery site. At this point, though, pretty optimistic about her outcomes. Our overall management strategy will include neuromuscular reeducation, nervous system and pain education, a big one, strengthening ASTIM, trigger point dry needling, and manual therapy. And that is our patient. That's our plan of care. Thank you for listening. Have a great day.